Good afternoon. First of all, thank you for being here. I know you all have other places you could be, patients that are gnashing at your phone lines and scratching at your screen doors trying to get in, so I do appreciate your time. Thank you very much. By word of warning, about 5 years ago I crushed my spinal cord, so it tends to make me a little gansy. So if I walk around the podium, and I apologize if I get out of frame on the camera, that's why. It's just a little difficult for me to stand in one place for a while. What I'd like to do today is try to make this really informal. Okay? In fact, today I complete 25 years at the university teaching medical students. So there's nothing you can do to me to interrupt me that's going to bother me. Just try not to throw anything that's sharp. But if you want to get up, go to the bathroom, get a drink, just make yourselves comfortable. I would really like to make this informal if that's okay with you. By the same token, this hour is yours. If what I'm telling you up here is of no value, you won't hurt my feelings. Just tell me it's crap. I'll throw the slides away and do something entirely different. I've got like 8 different presentations with me, so the idea is to make this of some value to you. Okay? One of the things that I would ask your indulgence on when we're done with the lectures is today we actually won the research award over in the poster section, and we came up with some really interesting things that actually has direct implication to clinical practice regarding kidney stones. And with your permission, I'd like to, when we're all done with the formal lectures, just take 5 minutes and show you what that is, because if you've ever had a kidney stone, you want to be here. And if you know anybody who's had a kidney stone, you really want to be here. It's probably the neatest thing I've been able to present to anybody in at least the last decade or so. So with that, let's get started. And please, if you have a question, whistle. All right, now here's my plan. Can't possibly do that, right? No way on God's green earth. Every one of those topics could be multi-hours. So what I'd like to do is say, okay, how do these topics fit together? Because at least in my practice, nobody ever had the decency to come in with one problem. Okay? They always, and it was always, they added 3 as they walked out the door. So for fair game purposes, if it's on this list, I'm throwing down the gauntlet, feel free to ask. As we touch on these topics, and we're only going to have like maybe 8 minutes a topic, but as we talk about these things, I'm going to try to relate how BPH is affected by testosterone and prostate cancer screening, PSA testing, and how that affects incontinence. So if you get the illusion that I'm skipping around, I apologize. What I'm trying to do is integrate the common topics in geriatric urology that affects the male patient and make it useful so that when you go into your offices on Monday morning, you're better equipped to take care of the plumbing problems. Is that a reasonable approach? Does that sound like that'll have some utility? Okay, and we can really go off the beaten track if you want, but try to make it useful. Okay, for those of you who don't know, I'm a bit sarcastic. I apologize. Okay, I can't help it. I went to law school. That's what the JD was on the initial slide. So I thought, like, okay, what would you need for a magic bullet in urology? If we just could give you a pill and fix all your male problems, what would you want it to do? Well, you'd want something to keep your prostate from growing. So that would be your 5-alpha reductase inhibitor. You'd like to have something that helps you go to the bathroom tonight, something quick in onset. Well, quick in onset is going to be an alpha blocker, something that's going to shrink your prostate or prevent prostate growth in the future. That's a 5-alpha reductase inhibitor, so we may need both of those. We all want to look like, be ripped when we're 60 and be strutting around the gym. At least that's what my patients seem to want. So we'll talk about testosterone replacements. We've got to put that in our magic bullet. And as we all get older, things don't work quite as well as we'd like, so we've got to throw in something there for our erectile dysfunction. So here was my magic concoction. Now I'm going to talk about, I'm not here to plug any of these particular drugs, but I think most of us use the trade names. But when I'm done in the next hour, I hope to be able to convince you why this particular cocktail would be what I would choose for patients. Okay? Or, more importantly, why you might want to choose something different. So my drugs of choice would be Avodart, 5-alpha reductase inhibitor, because it blocks both type 1 and type 2 5-alpha reductase. Uroxetrol, not associated with retrograde ejaculation, works really well as an alpha blocker. Androgel, you can slather it on. There's no adhesive to make your skin break out. It's not going to give you liver cancer, and you don't have to put it on your gums. And Cialis, for those of you who haven't been watching TV in the last decade, has a double function in that it's going to help you urinate, and it's also going to help with your erections. And the other thing nice about Cialis is it's a smaller dose, which in theory should give you fewer side effects like low back pain, headache, but it also has another little something special for you in that it helps you urinate. So what I'm trying to do here is we're going to boost your testosterone, we're going to keep your prostate from getting you in trouble, we're going to help you urinate tonight, okay, and we're going to make your penis happy in the process. Fair enough? Now, with that bit of sarcasm, let me tell you why I think I can justify this cocktail, assuming you have these problems. Just general information, because all your medical students who rotate with you know this, so I want to make sure that you remember it as well. The transitional zone is that part of the prostate that's wrapped around the urethra. So the problem is, as your transitional zone, or that area around the urethra, gets bigger, it squashes down on the urethra just like standing on a garden hose, cuts off your flow. It's that simple. Also remember that prostate cancer is what occurs peripherally in the gland. That's why we can feel it on digital rectal exam. Fair enough? Symptoms you're all familiar with: decreased force and caliber of stream, hesitancy, urgency. I mention these symptoms not because you don't know them, but because a lot of your patients think they're normal. Or at the very least, they think they're part of normal aging. Or they're so sure their normal aging changes that they don't mention it to you. So even though your patient doesn't come in and tell you about an obstructive, well, I killed it already, sorry. Doesn't come in and give you the laundry list of obstructive symptoms, you may need to ask about them because the patients may very well think it's a normal part of aging. And the irritate avoiding symptoms you're well familiar with. Things that happen to us as we get older, and again, I would just sort of ask you to think very osteopathically about your plumbing at this point. If your prostate starts to enlarge and it's wrapped around the urethra and it compresses the urethra, it causes obstruction. Pretty simple, right? But what happens is when you block up your plumbing downstream, what does your bladder do in response? Well, all of that in different orders. You're all right. You're absolutely all right. If you think osteopathically, what happens is if you increase the resistance, the bladder gets stronger, so it starts to squeeze. It has more oomph. It generates more force to get by the obstruction. Okay? The problem is at some point the bladder can't squeeze any harder than it already is. Urine starts to get left behind in the bladder after you void. That's your post-void residual urine. If you continue to increase the pressure in the bladder but don't fix the obstruction, you start to herniate or push the lining of your bladder out through the wall of the bladder, and that's what bladder diverticulum are. Okay? When you look inside a bladder and you see what looks like an unmelted cheese pizza, like something you'd get at Myers, those are bundle branches. That's hypertrophy of the wall of the bladder. The bladder's getting stronger, trying to generate more force. It's that simple. Now, here's where things get more difficult, though. If just as you started having trouble urinating, you started taking a green M&M every day, okay, your bladder would get stronger, and when your bladder got stronger, at least for a while, you'd urinate better. Okay? So that's why a lot of the research is difficult, because it depends where you are in your symptom course when you start your medicines. It's very easy to make it look like nuts and berries or bee pollen or whatever the flavor of the day is, and I would refer you to late night TV, okay? Pick your poison, to why a lot of men swear that these products work, okay? They did work. They just may not necessarily have worked for the reasons they thought. Urethral strictures are structural phenomena. We're not here to talk about that. So is BPH a problem? Well, yeah. If you don't do anything about BPH, it generally progresses. It gets worse. And if you have a bladder which is about to roll over the edge, it's it's going to decompensate, kind of like the left ventricle of the heart starting to decompensate or roll over the top of the Starling curve, if you remember those bad lectures. The same sort of thing happens with the bladder. It stretches so much, it gets so big that it can't generate any force, and it turns into a big hollow bag as opposed to something that can generate some oomph. So if you don't do anything, there's a risk of going into acute urinary retention or significant increases in your PVR, post-void residual urine, about 2% a year. Normal PVR is less than 50 milliliters after you void. Over 200 is clearly abnormal. Now, we always have to be able to justify what kinds of things we're doing to or for our patients. This is the IPSS. This is a standardized questionnaire that you can give to your patients to entertain them in the waiting room while you're waiting to see them. It's a way to calculate what their symptoms are before you treat them and after you treat them, and thereby justify them being on the medications, usually for insurance purposes. Well, okay? Now, I'm dead serious. Is this where you want to go? Is this may help on Monday? Okay. Then I'm going to keep blabbering until somebody tells me to do something different. Fair? All right, so we got our questionnaire. Medical therapy for the prostate, which is what most of us in the room are going to be dealing with. 2 goals. It basically either stops the growth of the prostate, or it shrinks it, or it opens up the hole through the middle of the prostate. Remember, prostate, walnut, hole, it's like a soda straw, like a McDonald's soda straw going through the middle of the walnut. Okay? So we're either trying to open up the hole, make the soda straw bigger, or keep the prostate from squeezing down or compressing the soda straw by its mass. Now, if you're going to try to reduce mass, that takes time. So 5-alpha reductase inhibitors take time to work. You can't have the guy come in acute urinary retention today and say, here's your Avodart, here's your Proscar. You got to be proactive. You got to get this guy 6 months, a year, 2 years before you think he's getting in trouble. Okay? You put somebody in a 5-alpha reductase inhibitor, takes 6 months for the prostate to shrink, and it probably continues to shrink for a year. Alrighty? Opening up the channel can occur either by making the prostate relax with an alpha blocker, or by making the prostate shrink, and as the parenchyma is reduced between the urethra, the hole through the middle, and the outer wall of the capsule, as that tissue shrinks, it pulls open the urethra. So either way, you're making a bigger hole through the prostate. Think mechanical here. Okay, Proscar's been around since '92. Readily available, Avodart 2001. If I say something about Proscar and you look at me funny and say, well, I didn't know that, I didn't hear that, let me know. The reason is I did some work with Proscar when it was still a protocol at Memorial Sloan Kettering Cancer Center, when it was still MK906. So this has been a buddy of mine for decades, and I may have some insight there that isn't generally put out in the literature. All right, remember the alpha blockers? They all started as basically antihypertensives. They were great drugs. They helped you urinate better, but the problem was in the middle of the night you'd go into the bathroom. It was really an antihypertensive. You perform a Valsalva maneuver to void and fall over like a big tree. Because of that, we started to come up with more selective and super selective alpha blockers, and that's things like Flomax and Uroxetrol. There is a host, there is a plethora of procedures designed to make a bigger hole in the prostate. And that's because half the population has a prostate, and if they live long enough, it's going to get them in trouble. So there is an ongoing search for safe, cheap, and easy, outpatient ways to get a hole through the urethra to facilitate voiding. And this is just part of that laundry list. Not every hospital offers all of these. Not every urologist offers all of these procedures. They are basically options.
How effective are these?
Thank you. There's the gold standard. The bottom line is if you really want to have a good hole through your prostate, you can't beat a good old-fashioned weed whacker or roto-rooter. Okay? The TURP, the transurethral resection of the prostate, is still the gold standard by which we judge all of these other procedures. Okay? The prior procedures, all in one way or another, are trying to make a bigger hole through the prostate, either by heating up the parenchyma of the prostate so that it gets reabsorbed, or by removing it using different kind of laser techniques. Bottom line is, it's possible to outlive your TURP. Because when you do a TURP or a remount somebody's prostate, you have left the periphery of the gland. That's why you're still at risk for prostate cancer after you have a hole drilled through your prostate. That's also because you still have residual prostatic tissue there. If you live long enough and your prostate keeps growing, you'll fill in the hole again and not be able to urinate. Now, that was a tremendous dodge I just gave you, and the real answer is, depends who did your procedure. There are some people who do a TURP and it's a little more than a little gutter cut down the middle of the prostate. They refer to that as a channel TURP, or I haven't got much courage, okay? There are other people who will do a TURP that will remove, in Japan they routinely will remove 150 grams of prostate during a TURP. They are very aggressive. So obviously those results are somewhat different. So the more tissue you remove, generally the better the result.
What's the risk of impotence with the TURP?
Higher than any of those other procedures I showed you. No, I'm not trying to be facetious. There are many urologists that do not even tell patients that impotence is an issue or a potential problem with a TURP. Okay, I don't know how many of you have ever had your patients come back and mention it. The other thing that happens is if you have a transurethral resection of the prostate, you also shoot blanks thereafter. Okay? Sperm aren't real smart. They don't know upstream from downstream, right? So when you ejaculate, if it's easier for the sperm to go retrograde or north back into the bladder, that's where they go. Well, it's not just your sperm, it's actually your total ejaculatory volume. So many gentlemen, after they've had a TURP done, will find they have little or no ejaculate that comes out. They're shooting blanks. Nothing is coming out, and it's a matter of resistance. Does that make sense? Yes, sir.
What's the effectiveness of those less invasive procedures you put out?
There's a procedure which called an interstitial laser coagulative prostatectomy, which basically puts a laser fiber through the wall of the urethra into the parenchyma of the gland itself, and then heats up the parenchyma. It liquefies the parenchyma, and then the body reabsorbs it. The chances of erectile dysfunction with that are essentially zero, and the same thing for retrograde ejaculation, because you're preserving the bladder neck. If you destroy the bladder neck, you get retrograde ejaculation. If you fricassee, well, no, I was corrected by a student of mine that was a chef, okay? Said fricassee is a white sauce, has nothing to do with deep frying. So the bottom line is, if you injure the nerves that cause erections, those nerves, the neurovascular bundles that lie in the groove, the posterior lateral grooves of the prostate, in other words, the prostate's here, rectum is down here, the nerves will be about here. If you have your TURP set hot or a lot of electricity, you transmit it through the prostate and you can damage those nerves. Okay? If you heat up the prostate with a laser trying to resect it, and you damage those nerves, you have erectile dysfunction. So anything that injures those nerves can cause ED. Fair enough? Yes, sir.
What happens to the urethra itself when you do any type of TURP? Since, you're going through the urethra.
Yeah, where'd the urethra go, right?
Yeah, where does that
Yeah. That weirded me out for the better part of my first year of urology. Bottom line, okay, you're now touring the penis, okay? We're coming down the soda straw. When you get to the base of the soda straw, you encounter the pucker spring, okay? That's your external sphincteric mechanism. Let's think of it like an anus for your urethra, okay? Little donut-shaped muscle wrapped around the urethra, pucker spring tightens down, so the urethra is completely clamped off. Once you go through that sphincter, you are inside the prostatic fossa. What a urologist sees is it looks like you're crawling into an old Boy Scout pup tent. The lateral lobes of the prostate the hollow part of the prostate does not form a triangle, forms more of a pup tent. And as the lateral lobes of the prostate enlarge, the sides of the pup tent collapse just like you pulled the tent pegs out. When you do a TURP, you're scraping out or lifting up the sides of the tent to give a larger passage to escape out the back of your Boy Scout tent. Okay? So you basically create a big cave inside the prostate, a defect, a TUR or a TERP defect, which then reepithelializes. It's actually urothelium, but
What about scar tissue?
really should not be. Scar tissue is more of an issue if they've used too big of an instrument in the urethra, where they've overdilated the urethra by putting too large of a resectoscope into the penis. You can develop scar tissue there. Sometimes overly aggressive resection of the prostate at the junction between the prostate and the bladder, the vesical neck. I mean, basically, you're reaming out tissue in a circumferential fashion around a hole, right? If you form circumferential scar tissue, right, around the bladder neck, what scar tissue do? It contracts. So if it contracts, you basically cause a narrowing or a defect at your vesical neck. That's usually the two places scar tissue bites you with TERPs. Okay, gold standard, 90. Was this popular? When I started my internship, and I did my internship in Fort Lauderdale, Florida, we did 18 of these things a day. Okay? I don't ever want to see another TERP as long as I live. It's like McProstate. It was appalling. Other ways that you can remove the prostate, again, same sort of thing. We've referenced the ILC. The PVP is doing the same thing that the TERP does. It's just using laser energy as opposed to heating the parenchyma.
Now, I asked you about how effective those other things were, like tuna, and I forget the other. I don't think you answered.
If you're looking for, I want one procedure in my life and be done, TERP. Okay? The problem is, again, in terms of how well are they done, how long are you going to live? The major advantage of the other procedures is they can be done as an outpatient with minimal or no blood loss, with little or no risk of retrograde ejaculation or erectile dysfunction. So it's all a balancing act. You know, if it's more important that you have good erections than you urinate, I can offer you this. If you're willing to take,
Say a good urologist does one of those.
Oh, they're all great.
procedures. And, okay, yeah, so procedures by other way. But what's the rate of effectiveness of things like tuna and those others?
Not as good, not as durable.
Is there data?
Yes, but that's a whole argument that's on another day. Yes, sir.
So, I'm a neurologist. If I have a patient that's going for a procedure, what does the surgeon usually say? Especially if I have a patient that's had TIA and stroke-like symptoms, what's the most common medication? Aspirin, or they get something else, they're on aspirin. The surgeon says, well, you gotta go off your aspirin for,
Right.
weeks. And it's what you take. And so, what's your thoughts on that, and where do you go?
Thank you. So the question is, what about anticoagulation therapy in terms of surgery to fix your prostate? And the short answer to that is, that's when you could come in with something like a PVP, a photovaporization of the prostate, where you may not need to discontinue their anticoagulation therapy to perform their operative intervention. And we also have other surgeries for even sicker people. There's a procedure referred to as the thermatrix, where we heat the prostate using a catheter through the urethra that has no blood loss. You can stay fully anticoagulated for that procedure. But the end result is not as durable, nor do we have as much long-term data as we do in a TERP. All these other procedures are 10, 15 years old. TERP's been around for 50 years. We know how that's going to work and how. We're not going to learn anything new about TERPs. We've been doing them for half a decade, or half a century.
I don't want to anticipate the other part of your lecture, but we'll be talking about robotic surgery and preconditions for against doing robotic surgery for BPH.
If we have time, we'd be happy to.
Then I will ask you then right now.
Okay.
It's a quick question.
Okay.
Okay. And basically, I've heard that if you've had a TERP or a vaporization or things like that, then you're not a candidate for robotic surgery.
Okay. It's not, yeah, okay. I got you. I know where you're going. Here's the problem. If you have a prostate and you have reamed out the center of it, you no longer have a walnut, you have a little bag. You have a rim of tissue. It is then far more technically difficult to do a radical prostatectomy for cancer because it's generally more stuck. There's the boundaries, the borders aren't as good. Because there's always some amount of damage to the sphincter in a TURP. It's just usually not enough to make you incontinent. Part of what makes us dry as men is we have an external sphincter and a prostate, sort of a dam to hold back the urine. If you remove the prostate, you then need to have an exceptional external urethral sphincter to be dry. If it's already been somewhat compromised by a procedure to treat an obstructive prostate, your results after your robotic surgery will not be as good. And that's also true with open radical surgery for prostate cancer.
So basically, an individual can be a candidate for robotic prostate surgery even if they've had previous procedures.
Yes. And the extreme condition is one of my first jobs in New York was we had patients, it was very, very popular at that time to implant radioactive pellets into the prostate to do brachytherapy to basically kill the cancer from the inside out. Radioactive source, usually either iodine or palladium, gets embedded into the prostate, kills the cancer over 6 to 8 weeks from the inside out. Well, that meant multiple holes through the rectal wall or through the perineum to get the pellets into the prostate cancer, and we were still able to do radical surgery. It's not every time I did when I swore, never again, please God, get me out of here. But it can be done, but your results in terms of incontinence and impotence are not nearly as good as a fresh prostate with a robot.
Is there less incidence of urinary leakage with like the laser versus TURP?
Yes. Yeah. Really, the whole issue is you're trying to keep the electric current from being transmitted, and you're trying to stay off of the sphincter. Again, back to the dark days of anatomy, remember we said we're going to go down the urethra, we're going to get to the pucker spring, we're going to see the collapsed Boy Scout tent. I'm not trying to be condescending. I'm saying this so you know how to talk to your patients. When you talk, so you have to translate what somebody else has said into English for your patients. On the floor of the urethra is a little bump, okay, at the 6 o'clock position of the urethra called the vireo-montanum, part of the ejaculatory system. That's the boundary. You don't want to come out and resect tissue closer to the operator than the vireo-montanum, because that's where the sphincter lives. That's where you damage people and increase their risk of impotence. Right? I'm sorry, incontinence. Okay? It's your hour, guys. Whatever. Yes, sir.
Have you ever heard of combining a standard TURP followed immediately by a PVP to get rid of the hanging shots and
Yeah.
bleeding and stuff?
Oh, it's great for the bleeding. Yeah, was it an older urologist? Only reason I ask is it's kind of like the older urologists, the people, the generation that trained me, were wizards with a resectoscope. I mean, they looked like they were using a steam shovel. They were throwing prostate over each shoulder. Okay? They were staggering, but that's all they had for decades. Okay? Then my generation came along and we had other options, and the art of TURP was lost. But some people said, wow, this PVP is really great for bleeding. So what they would do is they'd ream out the prostate because they could go faster with a classic TURP, and then they could use the laser. So yeah, it's all about furrowing that tunnel, okay? And and I would never object to what somebody preferred to use. The hospital may get a little annoyed in terms of utilization and getting reimbursed, but I've seen it done and it works. Okay, can I hit the next slide? We good? Okay. How am I doing for time? Because it's got to be ugly. We're good? All right. Never tell me that. All righty. So, moving right along, prostate cancer for fun and profit. I'm sorry. See, that's the kind of stuff that gets me in trouble. I apologize. There's nothing funny about prostate cancer. I know that. I did it for a living. I run my mouth without engaging my brain. I apologize. What's our strategy for cancer? Well, the bottom line is if your prostate cancer is still in the prostate or just barely through the prostatic capsule, the firewall, or just barely in the area around the prostate, we can fix it. We can cure it. Okay? Prostate cancer, which has spread outside of the treatment zone, we basically just try to slow it up, and basically we're all in a race to die from something. So the question is, will you die from something else before your more advanced prostate cancer gets you? Okay? So we want to catch it early while it still is treatable. All right. This just really seems like it ought to be obvious to all of us, but urologists did this wrong for decades. If you're going to treat somebody for a disease, ideally their life should be better after you've treated them. I mean, what a concept. There was a time when urologists went crazy with prostate cancer. It's like if they found a prostate cancer, they were like a dog with a bone. They had to operate on that. They had to get it out. And that caused us to do some really stupid things. I mean, we operated on men that weren't going to live another decade, on people that had other terrible diseases, okay, had bigger fish to fry. All right? So if you're going to treat somebody, ask yourself, are they going to be better after I treat them? Okay? And this little discussion we're having here is just aimed at trying to make people as good as they can be. So I'm trying to envision the guy that you meet at the health club who just got done training for his marathon that's 80, and the guy who is 60 years old that looks like roadkill. Okay? This isn't about age, this is about health. Okay? It's about expectation. Right? Trying to get people as healthy as we can for as long as we can, hopefully by being a little preemptive about it. And for those people who have had serious events in their life, what can we do for them even if we can't make them perfect? All right. Yes, sir.
There's a significant article in the Wall Street Journal a few days ago about prostate screening. I just wonder what your thoughts were on PSA.
Okay. I did not set this up, okay? We're going to talk about it. Are you all familiar with the United States Preventative Services Task Force? Okay. Bottom line is, they're sort of the ultimate arbitrators of do no harm. Okay? And this is pretty much in response to individuals who were screened for prostate cancer and were no better off because they found out they had prostate cancer. You gotta remember, if you tell somebody they have prostate cancer, even if they elect to do nothing about it, they're still not the same person before they knew they had cancer. It's sort of gnawing in the back of their brains. They're thinking, prostate cancer, am I gonna die from it? And every bad story they hear from their friend can become their story. So we're looking for people that we can screen. Now, things you need to know about this is these recommendations were based on PSA as screening and digital rectal examinations. And they said not a great idea in asymptomatic patients. Okay? The problem is this. I don't know about you guys, but I never saw an asymptomatic patient over the age of 50. No, I'm serious. I mean, do you get up at night to go to the bathroom? Once, sometimes twice. Oh, you just shot that when you're no longer an asymptomatic patient. Okay? Or we're going to do your digital rectal examination. Oh, Lord. Put your finger up their rump, feel their prostate. And that prostate that was 20 cubic centimeters when they graduated from college is now a walnut, which is about 40. That's not a normal patient anymore. So as soon as you see words like asymptomatic, the whole thing kind of rolls off the table. Okay? Also, this particular task force did not have a single urologist on it. Okay, funny you should say that. Now, what a surprise. Yes, sir.
Isn't the rate of rise of the PSA more important than the PSA itself?
Yes. And we'll get there in about a slide and a half. You're right on it. Absolutely. They hung primary care docs out to dry with PSA recommendations. I mean, what a phenomenal disservice, okay? They say useless things like the risk-benefit ratio, okay? Or have an educated discussion with the patient before doing PSA testing. Because you get about 5 hours with each patient every day to chat with them, right? You're supposed to advise them about their smoking and their weight loss and their exercise, and do they feel safe at home? And maybe at some point you'll actually get to talk to them about why they're there in your office, okay? So if it takes me 2 hours to discuss PSA testing with doctors, what kind of chance do you guys have in a regular office visit to talk about the risk-benefit ratio? It is absurd, but that's the reality, okay? So let me give you some little things that might make that discussion shorter, okay? For instance, the AUA, the American Urologic Association, does not agree with this task force. The American Cancer Society doesn't agree with this. The American Society of Clinical Oncologists does not agree with this, okay? Now, this would be my point in practice. All your patients have heard of the American Cancer Society. None of them have heard of this task force, okay? So if you're trying to reassure people and educate them and send them to sources that matter, that was sort of the approach that I took. Current recommendation is age 50, you're over age 50 unless you're in a particular high-risk group, you get your annual digital rectal examination and a PSA done. Okay, guys, if you're over 50, get a finger wave because you might have rectal cancer. Okay? Get a finger wave so somebody gets some blood on their glove and does a hemocult on you. Okay? So I don't care if you got a prostate. That argument for me is off the table. You're going to get a finger wave for those reasons, and they're also going to mesh on your prostate while they're up there. Okay? And that's kind of how I deal with this whole, should I have a rectal exam at age 50? Yes. And while they're there, let's also do your prostate. Okay? Now, things that put you at risk are being a member of certain groups. Okay? If you had your choice, you'd like to be Asian. Lowest risk of prostate cancer. Highest risk of prostate cancer, African American males, black men. Now, it's not a hugely higher percentage than Caucasians, but it is slightly higher. Okay? If you have a first order relative, okay, your brother, your son in some cases, your father, okay, you need to get checked. Okay? And here's the big thing nobody ever talks about. How old was your first order relative when they got prostate cancer? I would say to you that if your father got prostate cancer at 105, good job. Okay? Or if you want to know what your life expectancy is, one of my old trainers used to say, well, if they're 86 and they come in with their dad and their uncle, we'll operate on them. Okay? I'm serious. I mean, at some point, common sense is acceptable. Okay? But the problem is, PSA, and I'm going to abuse you with some of the historical crap that I put up with my fellowship, PSA was never supposed to be a screening test. Okay? PSA was developed, and here was the idea. You have cancer, we do something to you to hopefully fix you, and your PSA drops. And then we're going to follow your PSA, and if it goes up again, that's bad. That's what it's supposed to do, okay? But it did that so well, people just couldn't leave it alone. They kept saying, well, maybe we can use it for screening, okay? And for screening, there are things such as, I think it's actually farther in the deck, but I don't think we're going to get there. When we talk about PSA, we know that as you get older, your prostate gets bigger in most cases, okay? All prostate epithelial cells make PSA, which is a protein serase. It's what liquefies your ejaculate, okay? It's what makes it go from thick and white to liquidy looking. That's what your PSA is doing for you. I just completely had a brain fart. I apologize. Trying to get to where I wanted to go. All right, as you get older, your prostate gets bigger. All epithelial cells make PSA. So the more prostate you've got, the higher your PSA. Okay? That's where the idea of age-adjusted PSA came from. Because your prostate's probably bigger when you're 60 than when you were 40. So we put in a fudge factor that says your PSA can be a little higher when you're 60 than when you're 40. And then they said, well, that's not really what matters. It's whether or not your PSA goes up quickly. And that's where the concept of PSA velocity came from, where it's how much does your PSA change over time, but there's actually two sets of numbers for that. Whether your prostate is smaller than 40 cubic centimeters or greater than 40 cubic centimeters. So velocity is an issue. Then there's the issue of density. where you look at how big the prostate is and how much PSA is it pumping out. Okay? And then there are absolute PSAs. Okay? And just in case you still aren't completely confused, then there's free and bound. Okay? And now here's the part that I all want you to go home and swear you'll... No, I'm just kidding. One of my patients had a PSA done. They ran his PSA and the lab went to lunch. They came back, they accidentally ran it again. The first one was 3.6 and the second one was 13.8. When I asked them what happened, they said, do another one. It's like, no, this is not the Stanley Cup. You know, we don't do, you know, this isn't a series. This number should mean something. Okay? And still, in case any of you have a shred of belief in PSA, let me tell you that I have operated, in fact, the majority of men that I operated on for prostate cancer had a normal PSA. Okay? So if you have any delusions about PSA, I hope they're gone. Alrighty? If you want to know if you have prostate cancer, you diagnose cancer by getting a piece of it and looking at it under the microscope. Okay? And we'll talk a little bit about whether that's a good idea or not if we make it to hormones. Okay? Sorry, guys. I'm trying to hurry. Am I okay? I mean, I feel like I'm just up here like just, you know, throwing out one-liners. Hopefully there's some sense of integration. How do we treat prostate cancer? Radiation from the inside, brachytherapy from the outside, external beam, or combination, cleverly, where you do get some pellets and some external beam. Surgery, radical surgery. Again, remember, radical surgery, you take out the prostate and the seminal vesicles both. It is possible to have radical surgery and still preserve the nerves that cause erection. It's called a nerve-sparing operation. It's no big deal. Your urologist should be able to do it. Cryosurgery, just what it sounds like. You turn the prostate into a snow cone. You drop it down to about -40 to -60 degrees centigrade. You freeze it solid, then you thaw it, and then you freeze it again. Okay? And you can actually watch ultrasound. You can watch the prostate engulfed by this moving wall of ice. They're asleep for it. And the reason they're asleep for it is they're in a modified lithotomy. They're on their back, their hips are flexed at 90, and their knees are flexed at 90, and you put the freezing needles in through their perineum, in the taint, right between, okay? You familiar with taint? Taint the scrotum, taint the anus. Your patients don't use that? All right, so it's in the perineum, and the freezing needles are huge. They look like small crochet needles, and you generally put in about anywhere from about 10 to 20, okay? And that's because you're creating an ice ball at the end of the needle about the size of a grape. High intensity focused ultrasound, also called HIFU, under investigation, and let it never be forgotten, doing no active treatment but watchful waiting or expectant management, benign neglect, has a lot of names, where you don't have to actively do something just because you find cancer.
How do you monitor?
If somebody has prostate cancer, what we recommend that they do is that they have a digital rectal examination and a PSA determination. Because remember, PSA is helpful if we know you got cancer. Not good as a screen, but we do that every 3 to 6 months. And the idea is if your PSA goes up or starts to go up, you rebiopsy them. Because the concern is that they may have a more aggressive cancer hiding inside that gland. So your initial biopsy may have been well-differentiated, low-volume prostate disease, but when you rebiopsy them, you find out that there are other focuses of high-grade malignancy hiding in the gland. Okay?
Question.
Yes, sir.
Do you calculate what you're going to do depending on the Gleason levels?
Oh, absolutely. Yeah. In fact, Gleason is actually, there's a Gleason score, which is basically, you take the cancer, you look at it under the microscope, and you evaluate it on a 0 to 5 point scale. How butt ugly is it? 0 is not cancer, 5 is as ugly as it can get. And then you look at another spot, the second most prevalent pattern, and give it its score 0 to 5. And you add those two numbers together, and that's that is the Gleason sum score, which can be anywhere from 2, which is really well-behaved cancer, all the way up to 10, which is as ugly and wild as it can be. And it's been known for, probably 75 years, that the higher the number, the more likely you are to die from your malignancy, the more likely you are to have metastasis at diagnosis, the more likely it is to be locally invasive.
Question on proton beam therapy.
Yes.
How effective is that versus external?
Depends in the hands of the radiologist, the radiation oncologist, and those are numbers that can be very different. Part of it depends on how you define success, and every radiation center should be able to tell you what their numbers are because they run them every few weeks.
But they have newer units too, they're better.
Excuse me, sir?
Photons, don't they have better units, newer ones out now?
They do.
Apple's got one.
I'm not trying to hedge things, but what I am trying to do is be honest with you here. Radiation therapy views success differently than surgeons, okay? So if you see a study that says surgical success, that means you had a prostate cancer, we pulled that puppy out of there, and when we were done, your PSA was 0.00, okay? If you have radiation therapy, it's considered successful if your PSA goes down, but not necessarily goes to 0, okay? Some radiation centers only consider that you have failed radiation therapy if you have 3 consecutive PSA increases, okay? So you could have failed a year and a half in the past, but you're still being counted as radiation therapy worked, okay? So, and that's why it's sometimes difficult to look at these retrospective trials, because we're not really talking about the same thing. Okay, hormone treatment, bottom line is you have prostate cancer, getting rid of the male hormone testosterone is a good thing. Basically, you're cutting off the fuel supply. Testosterone is like gasoline on a fire if you're a prostate cancer. It's palliative, it doesn't cure anybody, and eventually the cancer figures out how to grow and spread without the benefit of testosterone. It's referred to as clonal or hormonal independence or hormonal escape. Removing testosterone doesn't cure you and it doesn't last forever, but it can be remarkable and it can last from months to decades in duration. The take-home message from prostate cancer: there's no free lunch. There's a downside to everything we do or don't do. Generally, healthy younger guys get surgery and older, sicker guys get radiation, but that is not at all how you need to judge treatment. There is risk and benefit to both surgery and radiation, okay? And those risks are common. Impotence, incontinence, bleeding, infection, death, okay? It's no free lunch.
You know, I don't see the rectal bleeding anymore like we used to see years ago.
From radiation?
Yeah.
Yeah.
It seems to have, whatever they're doing different, seems to have improved that.
Their aim's better.
Oh, there is one.
No, I'm not kidding, okay? When I started in this, radiation therapy was this way and this way, okay? As you start to pivot the radiation source around the cancer, each quadrant or wedge of tissue is getting a lower dose of the radiation. It's getting a 1/6, okay? So if you radiate or get radiation proctitis where you have torched the anterior wall of the rectum, you can have a lot of problems.
You said balloon now too, don't they? You stick it up in there, big balloon.
Yep, we got all kinds of toys in there now.
Lover's Lane.
Yes, and that is a different lecture that we will not videotape, but it's a way more interesting topic. Okay, all right, you ready? Can we switch?
Hey, Dave.
Yes, sir.
So, talking about PSA for screening, and you talked about why it's maybe not a good screening tool, but does the AUA and the American Cancer Society still advocate?
Oh, I'm sorry. Absolutely. Yeah, AUA, American Cancer Society, age 50, PSA, digital rectal exam. That still is our recommendation. Younger if you have a first order relative or additional risk factors. I'm sorry, yes, absolutely. Yes, sir.
The standard now of African American PSAs and a normal African American, is it 40 or 45?
45 for the moment, assuming there's no family history. We have a lot of trouble even knowing what the real incidence of prostate cancer is, okay? For instance, I can show you a direct correlation from the more biopsies you take of a man's prostate, the more likely it is to find cancer, okay? Most urologists will do between 8 and 16 cores of tissue. Harvard did a study where they did 100. They did not publish it. Actually, was a poster presentation. One of the great all-time honest findings I've ever seen. The correlation was the more biopsies you did, the less likely the patient was to come back. And I thought it was genius. It's like, you know, what a great demonstration. If you do bad things to people, they won't come back. So, but again, it shows that same kind of, the more areas you sample, the harder you look, the more likely you are to find cancer. And that is by no means a slam on Harvard. That was a gutsy thing they did. I was impressed.
Is there any consensus in any way as insurance companies, the government, as far as pulling PSAs at certain age?
I've never,
It's always got topic of conversation constantly.
I have not had any problems with them billing if you were within the American Urologic Association guidelines.
Stop doing them.
Oh, what age should you stop?
Yeah.
Oh, man, that's a great question. Live long enough, you're going to get prostate cancer. Okay? By the time you're 80, you probably have at least a 50 to 80% chance of having prostate cancer. So if you're 80 years old and we biopsy you, at least a coin toss you got prostate cancer. Okay? The question becomes, how likely are you to live another decade? Is your life expectancy another 10 years? If you're going to live another 10 years, I would argue that it's worthwhile searching for prostate cancer. Okay? It's like, if you're morbidly obese, you come into my office with diabetes, 2 heart attacks, and a pack of Lucky Strikes in your pocket, and you're 60, your PSA is not what we need to chat about. Okay? It's like you got to stay focused. It's like, we used to have people wanting to know, what was their cholesterol with metastatic kidney cancer. It's like, your blood vessels are wide open pumping blood to that tumor, sir. Don't worry. And sometimes we focus on what we can fix, not on what matters. Okay? And that's a big part of prostate cancer. Does it matter? All right. Testosterone, I hope that's what you're seeing. Okay. Testosterone, who gets it? All right, well, if you look at the ads, this is like fairy dust, right? Everybody wants to, there's yours, and we're all going to get testosterone. Well, 2 things you need to remember. You don't get testosterone supplementation unless you're symptomatic, and I'll show you that laundry list in a second, or if you are on blood test low, okay? And we'd have a whole discussion of, well, what's the best test, and generally, we're looking for 300 nanograms, less than 300 nanograms on a morning specimen. And, we can talk free and bound, and that's a whole other discussion. But take home 300. The idea is you want them to be low in the lab and have symptoms. Okay? What are the symptoms? Funny you should ask. Everything. It's like low sex drive, erectile dysfunction, fatigue, hair loss, muscle mass. I mean, everything except, your pizza gets delivered cold. Everything you can imagine, because potentially, I would venture to say that every man in this room probably has something on this list. Now, that doesn't mean we all get a sheep dip full of testosterone, okay? But if you have these symptoms and a low blood test, then we consider testing. Operative word, consider. Why? I'm sorry, I'm sliding ahead of myself here. Forms of testosterone, we got patches, gels, little things you can tuck under your lip, kind of like chew, injections, implants. There's even oral, which we do not recommend. Something I want to just mention about injections very quickly. If you get an injection of testosterone, which is a lot of times what the insurance company wants you to give, here's the problem. You get a shot of testosterone in your rump. It's a depot preparation, and your testosterone levels go super physiologic. And they're super physiologic for a week, and then they fall back down into the normal range for a week, and then for another week you fall subtherapeutic, and then after 3 weeks you come back in and repeat the process. Clearly not normal hormone replacement. Here's the other problem. Your testosterone's high in the morning, lower in the day. What happens with depo? It's high, it's high, it's high, it's okay, it's still high, right? It's not normal. It's not pulsing, and it's the wrong level. So I don't really care if you like patches or gels, but I'm not a real big fan of injectable, and that's why.
What choice do you have in insurance? It's all
I know. And unfortunately, and the problem is,
the patients need it.
I know. And the problem is, if the person has a problem, you're the guy they're going to say, well, clearly that exceeded the risk-benefit ratio, it's your fault. You shouldn't have given it to them. I mean, they really have done a great job of, putting us on the clothesline, guys. And why should we care? Well, there's some little problems with testosterone. Heart attacks, fluid retention, congestive heart failure, okay? Things you might like to avoid, blood clots, okay? Testosterone replacement therapy is not benign. That's why we don't just do it willy-nilly, okay? There are risks associated with it. And here's the best reason not to do it. We really, honest to goodness, haven't got the long-term studies to know what the long-term effects of this are. All right? So here's your risk, here's your benefit, and when I tell you what the risk is, I can tell you here's what I know it's correlated with, here's what it may cause, but long-term, don't know. Here are just some other little conditions that we may have talked about earlier today. BPH. If you give somebody testosterone, am I over? 5 minutes? I'm going to hurry then. If you give testosterone therapy 5 minutes, or 5, damn it. All righty, try that again. Prostate cancer. If you give somebody testosterone to a man with prostate cancer, it will grow. No doubt. And we know that because if you give somebody an LH-RH analog, something like Lupron, something that's going to cause a chemical castration, shut down their testicular testosterone production, it causes a very slight flare of serum testosterone after you administer it, okay? And that's why we have to block the testosterone surge, because we know it can stimulate the cancer they already have, okay? So it can stimulate cancer, can make normal BPH grow, cause blood clots, CHF, sleep apnea. Dear Lord. Alrighty. So what's the difference between giving you testosterone and doping? Well, bottom line is, when we supplement a man's testosterone, what we're trying to do is make him physiologically, hormonally normal. Okay? When you dope somebody, yes, sir. Okay, I'm going to take 2 minutes and then we're going to invest. That's a great question. The problem is this: if you give somebody testosterone, okay, their PSA goes up. And there also is a very compelling argument that says before you give somebody testosterone, you should at least discuss with them the possibility that if they have an occult malignancy of the prostate, you may stimulate it and cause it to grow, accelerate, or metastasize. And that's really not one of those debatable points. We've understood the relationship between testosterone and castration and prostate cancer since the 40s. They actually won the Nobel Prize for it, a couple of urologists. So your PSA will go up, okay? Just like if you give somebody a 5-alpha reductase inhibitor, their PSA will go down, okay? So if you give somebody Avodart or Proscar, their PSA should fall by 50% within 6 months. Okay, it's just the effect of the drug. We're not stacking drugs. We're not trying to give anabolic steroids. We're just trying to make them physiologically normal. Okay, I'm done. There's a bunch of other stuff we can do, but I apologize. Thank you.